Hey guys, welcome to your online lecture for understanding normal and pathological gait patterns. Your textbook usually starts with this chapter and the posture chapter first. However, I kind of disagree with that. I think the only way to truly understand gait and the normal and pathological patterns that might impact gait is to truly have an understanding of the pathologies first. So we've started the class with the foot and the toes. We moved into the ankle, the tibial-femoral joint, and last but not least, the coxofemoral joint. We talked about the different pathologies. We've talked about the joint arthrokinematics and osteokinematics. And now that you have a greater understanding of pathologies that can plague the joints, the way the joints should be functioning and moving, now we can kind of look at gait and really truly be able to evaluate it. We think about gait in general, what we're really thinking about is this idea that it's a key component of the assessment, but most importantly, it's a key component of the assessment of your patient's function. A lot of what we do in terms of assessment is with the patient on the table or with the patient in a closed fixed kinetic chain. In other words, we assess the patient in positions of dysfunction or no function at all. And truly the only way to get at how functional a patient is to have them walk. When we have them walk, all joints communicate with each other, and it's there that we can pick up any dysfunction that would arise. I think gait evaluation is also important because it really gives you the diagnostic information that you might need. There are things that you might miss in the evaluation process if you do not do a gait analysis. So most of the clinicians that I've seen generally always do a gait analysis, whether that injury is to the shoulder, the spine, the hip, the knee, etc. Generally, you should always do a gait analysis just to see if gait is actually impacted. So, as with any other lecture, we kind of have to start with a baseline definition or two before we actually start talking about gait and pathology. So the first definition that we're going to talk about is just what is gait. We think about gait, it's kind of this, I think, thing that we take for granted. It's a series of rhythmical alternating movements of both the trunk and the limb. So the upper extremity, right, is connected to the lower extremity. However, we spent most of our time in this class talking about the lower extremity for the most part. And then what we see is that when the two kind of connect and when they talk, what you get is this forward progression of the patient's center of gravity or your center of gravity. One research article that I read kind of described gait as a series of controlled falls, which I kind of find interesting, right? It's this idea that as we move one foot in front of another, as long as our center of gravity shifts with us, then we don't fall. And so there's this very fine line of standing upright and walking and having these series of rhythmical alternating movements and us being face flat down on the ground. And so we'll look at this patient with cerebral palsy and we'll kind of look at her inability to control her fall in essence, right? And so as I mentioned, gait is a series, things are connected, all joints, all limbs, and the trunk are communicating. When we look at gait, we have to be looking at so many different things, and this is why it's important that we spend 2 class periods versus 1 kind of assessing gait. As we're looking at this particular patient, we can see so many things, right? If we start at the hip joint, what we would see is she's not getting a lot of hip flexion, nor is she getting a lot of hip extension, right? Doesn't allow her to accelerate or decelerate very well. As we move to the knee, we can see, okay, she's got distal femoral internal rotation. She probably has a little bit of genu valgus. As we move to the ankle joint, clearly she's not getting any dorsiflexion at all. And then as we look at the toes, definitely no toe extension, right? These are things that we kind of take for granted, right? These are the things that every day God has blessed us with the ability to do. However, there are some patients who have either disease or are born with some type of neural issue that they have the inability to do what we kind of take for granted, which is to control falling. So with that being said, I mentioned center of gravity on the other slide. We think about center of gravity. Center of gravity is huge. It's instrumental in really allowing us to walk upright. It's really instrumental in making sure that we actually don't fall, and that's why gait is considered a series of controlled falls. We think about center of gravity. One of the interesting things about center of gravity is and what I'm learning is that as the patient kind of steps forward, right? We can imagine that. So if this person were to take their right limb and move it forward, what we would say is that the center of gravity is going to rise. So it's going to shift up and probably move with the limb that is moving forward, right? So it's adjusting so that the center of gravity is now focused on the limb that moved forward. Again, if center of gravity stayed posterior, then that patient might actually fall, right? Because we don't have center of gravity moving with us. When the patient is standing in a double limb position, the center of gravity lowers, right? In essence, it's going to be focused right in the center of the patient, around sacral level, maybe even lumbar level. So the center of gravity, in order to control our falls, will shift as limbs move or as the trunk moves. So we can see that the center of gravity has clearly shifted to the abdominal cavity. It's moved away from the lower spine. Now it's anterior. And it's also in the abdominal cavity. This is to allow or to prevent that patient from falling face forward on the ground. So center of gravity does adjust, and we're thankful for that, because if it didn't adjust, we just fall flat, either backwards or forwards every time that we walk. Some other definitions in the gait or in gait is what we consider the gait cycle. How do we kind of define what gait cycle is? Well, the best way that I can describe it is it begins when the reference foot contacts the ground. So this would be the beginning of gait, and then it ends when the same foot contacts the ground again. So the gait cycle, one gait cycle would be this starting point all the way to this ending point of the same foot, right? So right would have to touch down, or it could be left and then follow that through. It would be left all over again. So when we define gait cycle, it begins when one foot touches the ground and that same foot touches the ground again. Defining step length, that's the distance between two corresponding successive points of heel contact of the opposite feet. So on this particular graph, what we have is one foot contacting down. We'll say foot one, and then we have foot two, right and left. And so we would say step length would be this distance here, the distance between the right heel and the left heel of that particular shoe. Now, for the most part, unless the patient is injured, your step lengths on the right side and left side should be relatively equal or equivalent to one another. However, what you will find in an injured state is that is usually not the case. Either one step length, is longer or shorter depending on the particular pathology. Okay. Last but not least is the stride length, and that's the distance between successive points of heel contact on the same foot. So again, your stride length is the base or the heel of one foot and the heel of that same foot when it touches the ground. So again, we got stride length here, and then we have step length here, right? So heel of right, heel of left would be step length. Heel of left, heel of right would be step length as well. And then we have stride length, which is pretty much the equivalent of the gait cycle in essence, right? It's from one heel of the right foot, and the second time that right foot touches down the other heel. These measurements become only important when you're really looking at differences between left and right. Personally, I don't measure them clinically. I do look at them to see if there are differences, but I do not measure them clinically. Another key definition is what we call the walking base. The walking base is how wide a patient actually walks. So it's the side-by-side distance between the line of the 2 feet. And so this really represents the walking base, right? So patients, I guess this would be, I'm going to say right heel, patient's left heel, and you're looking at the width that it took to create these 2 steps. And females tend to have a wider stride width, and I think that makes sense, right? We have a wider pelvis, and as such, we're probably going to have a wider walking base. If what we see a lot of times is if the walking base is tends to be wider or more narrow, then you see this a lot in injured patients, or when they're trying to maybe reduce the amount of pain that they're in. So they'll adjust their walking base, they'll adjust their stride length, and they'll also adjust their step length as well. So Other definitions, the cadence is really the number of steps per unit time. And so what are some normative values? Around 100 to 115 steps per minute. However, there are some cultural and social variations. So I'll give you an example. Females tend to walk a little bit quicker than their male counterparts. But what is considered outside of the norm? A slow cadence would be considered anything that's less than 70 steps per minute. And then a fast cadence, like a super fast cadence, would be anything that's above 115, so anywhere approaching 120 steps per minute. And we can also imagine that in other different cultures, the cadence would also be different, right? Where females may be forced to walk behind males, so their cadence might be slower. So this is just a normative value, but it just depends on what setting you're actually in. So let's go velocity. Velocity is the distance that is covered by the body in unit time, and usually it's measured in meters per second. And believe it or not, velocity is the major predictor of functional disability in patients. And so we really want to, if we can, want to look at velocity. But again, it's very rare that we'd be able to do this unless, of course, we're in a gait lab where we can actually measure and assess such things. But normative values for velocity would be around 140 meters per second. And then last but not least, we have this thing called the comfortable walking speed. An efficient gait pattern requires the least amount of energy expenditure. So ideally, what you want is that patient to choose what we call a comfortable walking speed. This comfortable walking speed is what requires the least amount of energy expenditure per unit distance. For the most part, the average comfortable walking speed is about 80 meters per minute. And so you can kind of equate that to about 3 miles per hour if you kind of want to translate that into something that is more understandable. As we get older, you guys aren't old yet, but as you get older, the comfortable walking speed will obviously decrease, right? So as you get older, get ready for that comfortable walking speed to decline. So here are some normative values if you want to compare male and females. Again, you can kind of see some of the things are to be expected, right? Stride length and step length, both longer in males than in females. This has to do with the limb difference, has to do with the fact that men tend to be on average a little bit taller. So that's to be expected. The cadence overall is approximately about the same. What we do see, if you look at the gait literature, females tend to have a higher cadence than their male counterparts. The walking base, surprisingly, it shows males as being wider. It could be, there are several things for that. Males may need to walk wider because they have anatomical structures in between their limbs that would require them to walk with a wider base. So that could be one reason. And then foot angle, the direction at which the foot will kind of, I guess, evert. They tend to have a greater eversion moment at the foot than compared to their female counterparts. So we've talked about center of gravity. We've defined the different variables of gait. One other variable that I think is worth talking about is ground reactional force. Ground reactional force is the amount of force that the foot makes when the foot contacts the ground. And ground reactional force, to me, is probably the most important variable in a gait analysis, because what it tells you is how well that patient is distributing forces when the foot makes contact with the ground. This is a major predictor of injury in the lower limb, so the tibia in particular, and it has been linked to the increase in both medial tibial stress syndrome and tibial stress fractures and fractures. So when we look at these videos, what you're going to see is someone who's running and is in a shoe, and then you're going to see someone who's running and is barefoot. And so what you'll start to see eventually when both of these videos start to play is this peak right here. So notice that as this patient is running, what you will see is there's a peak here, and then it goes back down and there's another peak. Whereas here, the peak isn't occurring as as greatly. So what this means is that when you're running barefoot, the ability to control the amount of forces at the foot is going to vary a little bit. In other words, there is less of a dampening load when you're running barefoot than when you're running in a shoe, right? And that kind of makes sense. The shoe is going to protect you. Therefore, you're going to have this dampening effect right there because the shoe is protecting the foot. Whereas in a barefoot model, I mean, that force is just even all the way through. There isn't any dip or dive in that force. And so more forces across the foot in a barefoot setting than in a shoe setting, but that's to be expected. And this kind of fuels the whole barefoot versus shoe running and whether or not barefoot running leads to more injury. This would kind of provide evidence to that extent that, in fact, there are more ground reactional forces going through the foot. And so as such, those patients would be expected to probably suffer from more injuries. So that's the ground reaction force. Okay, center of pressure is important. Center of pressure is kind of goes back to center of mass. What it does is it tells us the patient's ability to really control the center of mass. In other words, can they really keep that center of mass centralized? And when they can do that, what you see is that they have more control in their gait. They have less dysfunction in their gait. And so being able to patients who have smaller center of pressure, it means that they have a better ability to control or to maintain or to keep that center of the gravity centered. Those that have larger center of pressures tend to have the inability to keep their center of gravity centered, which means they might be more apt to injury because they can't control where gravity is moving. All right, so here is a center of pressure graph. And so what you will see, ideally what you want, ideally, is for that patient to keep their center of gravity in this position, right? And when we see values over here on the right side, what we're saying is that they're spending time in supination, and then they kind of slowly move into pronation. So this represents supination, this would represent pronation, this would represent dorsiflexion, and then plantar flexion during gait. And so as they're standing, it's their ability to maintain the foot in a semi-supinated position, but then roll back over into plantar flexion, and then to keep that center of gravity centered, which this patient's doing a pretty good job of. Ideally, what you'd want is for them to be shifted a little bit more towards this midline here, and that would be the ideal model. What that means is that patient would spend less time in supination and be least susceptible to an inversion ankle sprain. So as we pick up and we're getting ready to talk about the gait cycle components, there are two different phases really of the gait cycle, either the stance phase or the swing phase. Stance phase is when a limb, we'll call it the reference limb, is in contact with the floor. And then the swing phase, as you probably already guessed or already know, is when the reference limb is not in contact with the floor, right? And so if we look at this image here, we'll see on the right limb is this would represent the beginning of the stance phase, right? And then this essentially represents the ending of the stance phase as that limb begins to leave the ground and move into the swing phase of gait. So ultimately, if you're in the gait literature and you're actually reading it, some gait researchers will actually say there are more phases to gait, but for the most part, there's either a stance phase or a swing phase. There's either a phase where the foot is in contact with the ground or it's not. So as we look at other things or other components to gait, we really have to consider this idea of single support and double support. Single support is only when one foot is in contact with the floor, and then double support is when both feet are in contact with the floor. So let's start with double support because I think that seems very intuitive. The points at which both feet are in contact with the ground are usually at the initial phases of everything, right? Initial phase of contact, pre-swing phase of the left limb, right? And then as we move towards the center, it'll be left limb initial contact, pre-swing of the right limb, and then so forth and so on. In terms of single limb support, we tend to spend most of our time in single limb support. And so what you'll see is as the pre-swing foot moves into the air, we're now in single limb phase for most of the contact phase or the stance phase of gait. And so these become important because what we want to look at when we're assessing gait is the person spending more time in double support than they actually should? And so as you increase the speed, right, you increase the amount of single support that a patient might have. In other words, the amount of time that a patient is spending on a single limb. And as you slow down gait, you increase the amount of double support that a patient might have. So when you're assessing gait, just keep that in mind. Okay, so I mentioned gait is broken up into really two subdivisions and or cycles. I'm going to start with the stance phase first. The stance phase is really broken down into what I would call 5 different categories, give or take. The first one is called heel contact or initial contact, depending on which article you're reading. In the heel contact or initial contact phase, it begins the instant that the foot touches the supporting surface. The instant that the foot touches the supporting surface, we are now in the initial contact phase. During this phase, the foot is very, very rigid as it approaches the surface. And we can kind of think of the subtalar joint being in a supinated position and the tibia a tad bit externally rotated. Additionally, what you will see is that because it's super rigid, the foot is also clearly the talocrural joint is also in dorsiflexion. So initial contact, the instant the foot touches down with the ground. During initial contact, please remember we're in double limb support. Both limbs are in contact with the ground at the same time. This is the first double support period of the gait cycle. So it's the very first double support period that you might see, and it only represents about 10% of the total gait cycle in general. This is also the point when the center of mass is at its lowest, and that makes sense, right? The foot is moving forward, therefore the center of mass is going to be lower. As we move or progress from initial contact or heel strike, what we then move into is what we would call either the foot flat or the loading response. The loading response or foot flat or foot contact stage occurs immediately after initial contact, which I guess that makes sense. And during this period, the limb is going to be best at reacting to and accepting the impact of body weight. So it's preparing basically the body to withstand the weight of the total body of that particular patient. This is the first, the body weight is then advanced onto what we call the mid-tarsal and subtalar joint. And the subtalar joint now begins to pronate to allow us to absorb the shock. This period lasts until basically the opposite extremity has left the surface and double limb support has ended, right? So let's think about that. In initial contact, we have this massively rigid foot. It's in dorsiflexion, it's in supination, right? And the idea is this is the first time that the foot makes contact with the ground. Lowest point in terms of center of mass or gravity. And then as we move into foot flat or the loading response, what we get here is the body trying to adapt and accept the impact of the body weight. Remember, we talked about foot flat position is a bag of bones. It's the ability of the body to take the ground reactional forces and to transmit them, right? So foot flat position is that positioning. Is that position at which the body weight is advanced onto the mid-tarsals and the subtalar joint begins to pronate, the tibia begins to internally rotate, and then we're able to accept those forces that are coming through our body. I don't know about you, but I just got excited about that. So we've got heel strike, we have foot flat. Next, what we have is mid-stance. Mid-stance begins as the body weight moves directly over the support limb and stationary foot. So what we can see is at heel strike, kind of have body weight posteriorly. At foot flat, we still kind of have body weight posteriorly because this limb is still posterior. And then as we progress to mid-stance, what you will now see is that the body weight is kind of in line with the actual ankle joint. At this point, the foot is flat on the surface, so it's completely flat. And the knee is in a stable position, so it's locked in essence. And what we see in this position is that the center of mass is at its highest, right? So from here, what we would say is it's at its lowest, right? It's going to be centered here. And as we progress to this mid stance, because the body is aligned to the ankle, it is now in that centralized position on the sacrum. So we progress to initial contact where the foot is massively rigid, to foot flat position where the foot is a bag of bones and is absorbing all of the ground reactional forces, to mid stance where the body's really being prepared to kind of move into the next phase of gait, essentially, because now we're in massively single limb support here, because this limb, the left limb, is no longer making contact with the ground. So last but not least, what we have is terminal stance. And terminal stance begins as the center of gravity kind of passes over the foot and ends just before the other limb makes contact with the ground. So it's kind of like this in-between phase right in here. The body basically moves ahead of the supporting foot with the weight shift over the metatarsals. So whereas here we had weight over the mid-tarsals, here we have them over the metatarsals, right? The most distal part of the phalanges, essentially, where we're getting ready to kind of toe off and go into the swing phase of gait. So we really have, I would say, 4, but maybe 5. Some people include what we call the pre-swing of gait, into the stance phase. And so I've included that here because that's, I think, what your textbook does. Pre-swing is the final period of the stance phase. So it's the last point at which the reference limb actually is making contact with the ground. It is the transitional period of double support during which the limb is rapidly unloaded from the ground and then is being prepared to swing forward. So again, we talked about double limb here. We've got double limb, massive double limb. We transition into single limb as we move into mid stance, and then we're transitioning back into double limb as we prepare to swing that reference limb that has been in the stance phase for so long into the swing phase of gait. So the pre-swing gait is just as important because it's really preparing that limb to accelerate over into the swing phase of gait. As we mentioned, swing phase of gait, there are 2 phases of gait. We've talked about the contact phase, and now we'll talk about the swing phase of gait. The swing phase of gait really is simple. It has 3 different phases. Some people call it acceleration, mid-swing, and deceleration. Some also call it the initial swing, mid-swing, and or terminal swing. So it just depends on what you're reading. So I've given you both definitions. During the initial swing of gait, it begins at the point when the toes leave the ground. So right, we go from pre-swing kind of to initial swing. And what it does is it creates a propulsive force that continues until the knee kind of reaches maximum knee flexion, right? We can imagine that it's kind of going to look like this. There's maximum knee flexion here. And now what we're really ready to do is kind of propel forward in essence. And in mid-swing, what we tend to see is that the knee goes from this maximally flexed position to a somewhat extended position so that the tibia kind of reaches this vertical position with the ground, and basically the thighs are essentially ready to kind of just propel the body forward. And then last but not least would be deceleration or terminal swing phase, which is the final period of the swing phase. And during this phase, what we're basically doing is preparing the body to make initial contact all over again, to start the contact phase. So I feel like the swing phase is probably the most intuitive phase. We look at the gait cycle as a whole, right? Which we kind of did when we started this. It just becomes important to always remember that you have to only look at one limb or assess one limb at a time. And I think this image does that for us. And this is the right limb. It's making initial contact. So it becomes important to understand what's happening at initial contact. What, if anything, if there's injury to the ankle joint or the foot or the knee, might that have an impact on the initial contact as we move from initial contact into the other phases of contact, right? your foot flat, your mid stance, your pre-swing. And as we move into the swing phase of things, then what's happening there? The knee has to get into maximum flexion. The hip has to kind of go into extension to allow for acceleration into that mid swing phase, where the knee now becomes a little bit more extended. The tibia is going to be perpendicular with the ground, and it allows us again to make initial contact and start all over again. Again, remember, there are periods where we're in double limb support. There are massive periods where we're in single limb support, and those will change depending on what the patient is doing. So some of you might ask, okay, so what percent of the gait cycle is what? What we tend to see is that 60% of the gait cycle tends to be stance phase, and 40% of that gait cycle tends to be the swing phase. In other words, we're going to spend 60% of our time in contact with the ground. The limb's going to spend about 40% of the time not making contact with the ground. And then in terms of single versus double limb support, approximately 40% of the gait cycle is single limb, and about 20% is double limb. And then that extra 40% that's missing is somewhere in between the two. Okay, so what happens as we increase walking speeds? So what we tend to see is in sprinters or runners is that they have less of a stance phase and more of a swing phase, and double limb support decreases, which I've already said. In other words, as you begin to run, you make less contact with the ground, and you have less double limb support, so less initial contact, pre-contact phases. They're shorter as a result, and that makes sense. But it also becomes very important to understand this as you're assessing a patient's gait who is a sprinter or a runner, etc. So running, by definition, walking without double support. The ratio of stance to swing reverses. In other words, you're probably going to be 60% swing and 40% stance. And ultimately, in your sprinters, that double limb support disappears completely. And now you have basically what we call double swing, which is where you're just spending so much time in the air. And this is good. We really do not want our runners to have 60% stance phase. What's that mean? Increased chronic injuries, increased injuries throughout the entire kinetic chain. So again, such a beautiful design that we have in terms of the human body. What do we know about gait? Gait requires really low muscular demand. Approximately 20 to 20% maximum muscle strength is required, which is the equivalent to like a 3 out of 5 on a manual muscle test. And so tomorrow, when I see you guys, I'll give you a handout on what muscles are actually being activated during the actual gait cycle. So gait pathologies, oh man, there are so many. Let's start with probably what we would see most often. The first one that we see most often is a pronation deformity at the subtalar joint, if I'm being specific. We already talked about what pronation is. Now we're going to see why being a hyperpronator could be detrimental to a patient who is a runner or who tends to spend a lot of time in the stance phase of gait. So we're going to look at a video in just a moment. But what we see with excessive pronation is a few different things. Number one, that excessive pronation tends to be linked to a genu valgum. In other words, you have genu valgum at the knee, and that leads to hyperpronation, which could be coupled with a few different things. It could be coupled with a leg length discrepancy. Generally speaking, the limb that is hyperpronated will be the longer limb. It could be associated with some type of hip muscular imbalance. Most often it's usually the glute medius that's weak, or it could be associated with the type of shoes that the patient is wearing. And so we have to identify a hyperpronator or a person who excessively pronates, because as the patient pronates and spends a lot of time in that mid-stance phase, the biggest concern is that they're absorbing too much force in the foot, which obviously could lead to several different things. We could talk about increased pressure on the first metatarsal phalangeal joint. We could talk about increased load to the tibia, and then what that leads to: medial tibial stress syndrome, periostitis, tibial stress fractures. And so when we start our gait analysis of a patient with excessive pronation, we always would look at a patient's shoe, prior to assessing their gait, because they will have a different wear on their shoe, right? More than likely the inside or inner posterior sole of their shoe will be worn. When you're looking on the inside, they'll have maybe a cavity or a hole where the first metatarsal joint sits. And then most often, sometimes patients with excessive pronation, if it's linked to the genu valgum, will also complain of medial knee pain because you're stressing those medial structures. So let's take a look at someone who has excessive pronation while running. Oh man, it's not working. Okay, so in class, I'm sure we'll have someone who has excessive pronation. We tend to see excessive pronation from a posterior perspective. And so most people think that you would catch it when the patient's walking towards you, but in fact, it's the opposite. You catch it when they're walking away from you because you see the calcaneus start to evert. And so most often pronation abnormalities are most often found when you're looking at the patient as they're walking away from you. So key in on that tomorrow in lab. Okay, we also have, so we've talked about hyperpronation. You can also have a patient who walks with a toe in or toe out position. Remember, we talked about this with anteversion and retroversion, right? Where a patient might have a toe in or a toe out posture. So if you identify this in your gait, we have to rule out hip anteversion and or hip retroversion, just to make sure that in fact your patient doesn't have a coxa vera or a coxa valga or any other coxofemoral abnormality. But generally speaking, if we see a toe in or a toe out gait, it's most often found in mid stance or just after toe off. In other words, pre-swing, when they're getting ready to go into the stance phase of their gait. So we have to be specifically looking for a toe in or toe out posture mid-stance or just before they push off. What are some of the causes? There are many different causes. I would honestly say that it's been linked to tight hip muscles. So tight either hip internal, external rotators, but you can also have it be linked to just tibial rotation that's occurring. So whether or not, Tom, Dick, and Harry is super tight and driving tibial rotation internally, or you have something like, let's say, biceps femoris, maybe driving tibial rotation externally. It could be many different things. If you identify the toe in or toe out, and from a differential perspective, the first thing that I want to rule out is whether or not they have some type of coxofemoral abnormality, and then I would go to the tibia secondarily. Most often when you see these, though, it's usually some sort of muscle imbalance, tightness and or weakness on one side or another. But what does it mean if a patient is spending time in a toe in or toe out position? In a toe in position, what you tend to see most often is stress on the lateral soft tissues. Specifically, the tissues that get stretched the most are the peronei or the fibulari muscle group. And so they tend to be placed in a lengthened position, which means that they may not shut on when the foot goes into inversion. In other words, they may not tell the foot, no, don't go in inversion, I'm going back out into eversion. So that becomes a potential problem. In a toe out position, clearly if you're in toe out, probably pronation associated with that, maybe some genu valgus, and what you tend to see is stress being placed on the medial structures of the lower limb, as well as the plantar structures as well. So this patient might complain of medial longitudinal arch pain, tibial pain, you name it, okay? I don't think any of my videos are going to work, which just bothers me. But we'll look at these gait patterns in lab. I'll keep going. Okay, so a shortened step length. Okay, what would cause someone to have a shortened step length? One of the things that would cause someone to have a shortened step length, and most often when we see it, is following some type of injury to the lower limb. In other words, you have a hip injury or a knee injury or an ankle injury, and stepping too far causes so much pain. So you decide to shorten your step length, and that kind of changes your gait. So that's one way, right? You shorten your stride so that you decrease your symptoms. You're not making it worse. The other thing is when you shorten your stride, the impact isn't as great. And so it's one way to reduce pain in patients who have hip, knee, and or ankle issues. Another reason that you could have shortened step length would be if you have inadequate push-off. So if the triceps serrae, let's say a patient was immobilized for maybe 3 to 6 months and they have a weak triceps serrae, so now they have lost the ability to push off. And then inadequate pull-off. So if the hip flexors are compromised in any way, shape, or form, these would all be reasons that a patient would have a shortened step length, and you would have to assess that. Is it pain? Is it weakness in the triceps serrae and or the hip flexors, right? They're losing their ability to flex the hip and allow that patient to move to the acceleration phase in the swing portion of gait. Shortened stance time, right? So in other words, this person does not want to stay in contact with the ground. Most often we see this in an antalgic gait. This is a gait pattern that a patient adopts when they have an injury. Most often it's an ankle injury, but they will limp. And so when they limp, they actually spend less time in the stance phase, specifically in the mid stance phase, because that's when most ground reactional forces are going up the kinetic chain. And so they will try to avoid the mid stance and pre phase. Other causes of a shortened stance time would be pain, again, either acute or chronic. The big deal with shortened stance time is this idea that they don't want to load the joint. They don't want the ground reactional forces to go up the kinetic chain. And so as a result, they shorten the amount of time they spend in the stance phase. Now, if this is the case, the recommendation has honestly been to put the patient in a non-weight bearing position. That could be crutches on this campus, good luck. It could be a protective brace. It could be a scooter. It could be all kinds of different things. One of the reasons you don't want a patient to practice having shortened stance time is because we see an overuse of the hip flexors most often with this, because now they're spending more time in the swing phase. We also see an over lengthening of the hamstring muscles as a result, because they're spending so much time in hip flexion. So it's just not a win-win situation. And then ultimately it alters their normal gait pattern. So it's just, if you see someone with an antalgic gait pattern, the recommendation is to place them into a non-weight bearing position until they can have or restore normal gait patterns. Okay, next we have unequal hip height. Most often, unequal hip height has been linked to a leg length discrepancy. And so this is what we would call an anatomical true leg length discrepancy. However, there are other reasons that you would have unequal hip height in a patient in the lower extremity. One of them would be a glute medius weakness. And we're all going to do a Trendelenburg's gait. So you can see exactly what that looks like, but we can all remember what Trendelenburg's test would look like. The inability of the stabilizing or stance limb to stabilize that pelvis, so that opposite pelvis is going to drop down towards the ground. Okay, some things in the upper extremity that might also have an impact on gait, and the one thing that we want to look for is what we call an asymmetrical arm swing. Arm swing counterbalances hips and pelvises. And so we tend to have larger arm swings as we're running, right? And that would make sense. And then I guess shorter arm swings as we're walking, not as much energy required, so we don't need the arms as much. What would cause some asymmetrical arm swings? Well, the obvious would be an upper extremity injury. I think the least obvious would be a leg length discrepancy. Remember what we said, arm swing counterbalances both the hips and the pelvis. So if one limb is longer or shorter, so will the arm swing of that particular limb be as well. So that's one thing that we can kind of rule in if we have asymmetrical arm swings. And the other time that I've seen an asymmetrical arm swing is in a scoliotic patient. And a scoliotic patient that has at least a 30% scoliotic curve. And part of that is as the curve increases, or as there's increase in the scoliotic curve, so does the arm swing of the side that is impacted. So what do we do for these individuals? This one's kind of a hard one to treat. We have to teach them posture. We have to figure out if it's a leg length discrepancy. Can we solve that with an orthotic intervention? And then with scoliosis, the big deal would be bracing them if it truly is impacting arm swing during gait. Okay, so plantar flex ankle at initial contact. So remember, we said initial contact, one of the most important pieces is that the foot is in a locked position. It's in a dorsiflex position. So what things might actually make the patient be plantar flexed when they are initially making contact with the ground? One of the most common things that we see it a lot in cerebral palsy patients, is gastrocnemius spasticity. They are so spastic that the foot can only be kept in plantar flexion. And so when they make contact with the ground, pretty much they are in a plantar flex position. And we saw that with the young lady who had cerebral palsy early on in this particular video or PowerPoint. Drop foot, if we have, let's say, a nerve pathology. So let's take an anterior compartment syndrome that's compressing the nerve, and it's preventing the foot from dorsiflexion. And so, in other words, it's not so much that they're spastic and they're stuck in plantar flexion. It's truly just that the foot cannot get into dorsiflexion due to a lack of neural supply. We can have a hamstring pathology. So here's the thing with hamstrings. Ultimately, you wouldn't think that hamstrings can contribute to dorsiflexion, but secondarily they do, because in order to really get good dorsiflexion range of motion, you have to stretch the hamstrings a bit. And so if you have a hamstring strain, what you will tend to see is as that foot goes to make initial contact, the patient will either have less dorsiflexion range of motion so that there isn't as much pain at the hamstring group, or they'll have more hip or knee flexion to shorten the hamstrings as well. So you'll see either one of those two changes in gait. A foot flat stance. Oh, maybe this one will play. What we see, let's see if it'll play for us. In a foot flat stance, what we tend to see is the patient has no initial contact. Like normally you would see the heel make contact with the ground, and then you would see like the transition of the body moving forward to a foot flat stance. But if you look at this patient, that truly is not the case. In this particular patient, he literally just starts by loading the midfoot. And that can be a problem, right? Because if you don't transfer force smoothly and you're just loading that midfoot, you can suffer from navicular fractures. I've seen patients suffer from a massive arthritis at the talocrural joint. So what are the causes of a lack of initial contact, or just going into a foot flat position? An ankle sprain will do that to you. Specifically, if there's pain and the patient just does not want to make contact with the heel, they'll kind of try to load the foot to avoid dorsiflexing the foot. Another one might be a gastrocnemius strain. In other words, like if a patient has a strain to the gastrocnemius, they're not going to want to dorsiflex because that's going to stretch the gastrocnemius. So they'll try to avoid stretching by just going into a mid-stance phase. Okay, man, there's a lot of pathologies, huh, guys? I think we have 3 more pathologies. Another one is an inadequate ankle plantar flexion angle. So in other words, there's a decrease in ankle plantar flexion at push-off, right? So that's when we're actually getting ready to move from stance into swing. And so this idea that we need to be able to propel or to push off is very important. Biggest cause of this is honestly decreased strength in the triceps serrae. However, it also has been linked to an acute ankle sprain. What we see with acute ankle sprain patients is they don't really want to plantar flex maximally because it stretches the ATFL. And then the last thing or reason that we may not see really good plantar flexion during push-off would be a forefoot pathology. In other words, the patients do not want to load the metatarsal heads. They don't want to load the forefoot because it causes pain. And most often you see this if a patient has like a stress fracture, a contusion, metatarsalgia. So these patients will have less of a plantar flexion angle, which means they won't be as explosive. And that becomes important if you're a sprinter and you need to explode. Excessive knee flexion angle at contact. So normally during initial contact, the knee is near full extension. At contact during walking. So during running, there's a little bit of flexion that occurs, but for the most part, it's in full extension, right? And we need that to happen. The ankle joint needs to be locked, the knee joint needs to be locked, and this becomes important because it allows for the gravitational forces to be transferred up the kinetic chain. So some causes of increased knee flexion at initial contact would be hamstring strain, right, or adductor strain. Either of these 2 types of strains, if we have the knee in full extension, will cause pain to the specific muscle group. So that could be one thing. You could have a tight hamstring or a spasm of the hamstring. So if the hamstrings are tight or if they're spasmed, clearly we're going to have more knee flexion at initial contact than we would if they were of normal length. And then last but not least, but definitely something to consider, is the sciatic nerve pathology. That could be piriformis syndrome or a herniated disc that's pressing on the sciatic nerve. Reason you have more knee flexion than you normally would is because knee flexion kind of takes the stress or the strain off of the sciatic nerve, and it doesn't exacerbate the signs and symptoms. So those are just things to look for as you are assessing gait. Okay, inadequate knee flexion angle during stance phase. So during stance phase, normally the knee flexes to 20 degrees during stance phase, right? So we're not talking initial contact. We're just talking as we progress from initial contact to mid stance phase, there's some knee flexion, right? And so this has to kind of occur, and we want it to occur to dampen the forces that are occurring across the tibial femoral joint. But however, sometimes it doesn't, right? And so sometimes you might be in like mid stance phase and you're still extended with no knee flexion, and that's not a good thing. So what are some causes for that? Quadriceps pathology would cause that. In other words, the knee might be in more extension because when you flex the knee, the quads get stretched. In other words, if you have a quadriceps strain, it doesn't want to get stretched, so it shortens up, and because of that, you have less flexion during the stance phase. And then also patients who are in joint pain, what we tend to see is that they tend to like extension. Part of that is because the patella is making least amount of contact in the patellofemoral joint, and so it will reduce the amount of contact forces across the knee joint. And so that's one reason that you might see a little bit more knee extension than you do flexion in a patient who has a quadriceps pathology or some type of knee joint pain. Okay, two more, guys. Inadequate knee flexion during swing phase. So we can imagine that if the knee was extended during swing phase, we would probably just fall forward, right? During the swing phase, the knee is normally flexed to anywhere between 30 to 60 degrees during walking, and for sure at least 90 degrees during running. It becomes very important that you have adequate knee flexion during the swing phase of gait. So there are times where this isn't the case. Most often, if we don't have adequate knee flexion, it has been linked to hamstring pathology. Most often, if I had to pick on this list, it would be strains first and foremost, and then probably sciatica secondarily. And then clearly, massive knee flexion would essentially maybe place more strain, in other words, cause the hamstrings to work more, and they may not want to. So we really just have to be careful when we're assessing pathologies for gait. Inadequate hip extension at terminal stance. Well, during terminal stance, we have to have hip extension as the body is propelled forward. In other words, it's almost like a rubber band. As the hip goes into extension, it kind of winds up and it gets us ready for the swing phase. So major causes to a lack of hip extension would be the opposite of the hip extenders, which would be a contracture of the hip flexors. So much so that it's inhibiting the hip's ability to get into a hip extended position. Now, I've listed one cause. There are many others, but ultimately the most common cause of a lack of hip extension would be the contracture of the hip flexors. Last but not least would be forward trunk angle. And so the patient's leaning forward versus erect. Most often you see this accompanied with some type of low back pain pathology, but you can also see it associated with either a painful hip flexor, so they're kind of flexing in the position of comfort, and or weak ankle plantar flexors. So if you have weak ankle plantar flexors, something has to compensate for that, and usually that's the trunk. So my goodness, I think we kind of went through a lot of slides. We did. The idea is this, that you have to know the definitions of gait. If you can't tell by now at the end of this lecture just how important it becomes for you to evaluate and to know the different phases of gait and what is occurring in each of the phases of gait, then I failed. So tomorrow in lab and Thursday in lab, what we're going to do is kind of dissect the different phases of gait and the pathologies that might actually occur while you're assessing gait. And hopefully by the time we finish this week, you'd be able to identify abnormalities in gait and maybe even come up with a fix, if in fact it can be fixed or is fixable. Anyways, thank you for listening to this lecture. I'll see you guys tomorrow.